It's noon right now. So why don't I get started with the official introduction? I don't want to take all the prime time away from you, Tim, but just wanted to get the party started. It's exciting. So everybody, welcome to inaugural Methods Monday. I'm just so very excited that we're actually starting this year off with Dr. Tim Hanna, who I'll introduce shortly. We've been talking about having a methods sort of series for a very long time. There are so many incredible faculty, analysts, project managers at HSPRI, and we're always looking at the incredible brain power we've got here, and just thinking about ways that we could share everyone's brain power with everyone else. So our rounds so far have really focused on results of studies. And so we thought, what better thing to share everyone's brain power than to go a little bit upstream in the research process and open up the HSPRI methods box. So it's great to see a whole range of people here today. So from learners, faculty, staff, and really that's the idea, is to start to share some of this knowledge to do better research. So before we get started, I just wanted to acknowledge that those of us attending from Kingston are situated on the traditional Anishinaabe and Haudenosaunee territories. And so I just want to start by offering my gratitude for these lands for which we come together to learn and ask questions. I also wanted to let everyone know that I recognize that Indigenous communities continue to face inequities as a result of systemic racism. And I think as researchers, it is really through our thoughtful and informed methods and approaches that we can start to address these disparities through this work. So I'm going to put up in the chat some important work that's been led by Dr. Amrita Roy in collaboration with the Frontenac Leamington and Addington OHT. And she worked to develop a toolkit of Indigenous focus approaches and evaluation indicators for health systems. And I encourage you to all take a look if you have time today or in the next week or so, to really think about how you can incorporate some specific Indigenous focused methods and approaches, and think about how we can do that. So I'm going to put that link up for everyone to take a look at. But I am also very excited to introduce Dr. Tim Hanna. I could go on for a long time about Tim's background, but I'll cut it short so he can share his wisdom instead. He was recently appointed the Teachers Association of Queens, so CTAC chair of Applied Health Economics and Policy. And so as soon as that happened, we quickly nabbed him to be the inaugural presenter here today. Dr. Hanna, Tim is a primary investigator at the Division of Cancer Care and Epidemiology at Queen's Cancer Research Institute, and an associate professor in the Department of Oncology. And he's also cross-appointed to the Department of Public Health Sciences and the Department of Medicine. Tim is a radiation oncologist and a senior adjunct scientist at ICS, and he will tell you and talk today about using ICS data for economic analysis. And I personally am very keen to learn more. I'll hand the floor over to you, Tim.
Thanks, Catherine. It's a real privilege and honor to be here to chat with you and have a conversation. I'm excited to share with you and to see how this goes, talking about methods on Monday. It's great. I'm going to try to share my slides and see how everything works here. All right. Okay. And I'm going to turn this into full screen. Is that coming through okay? Yeah. Okay. All right. Great. I'm just gonna move the video so I can see my slides while I present. And in my view, I can't see hands or really look at the chat, but I'm happy to stop as we go along just to have a deeper conversation if there are particular points that that stand out to you. I have a lot of slides and I don't need to talk about all of them. So so please, I'm happy if you have some particular questions. All right.
And Tim, I could be your backup on this side. I'll monitor the chat and I can look at any hands that I could jump in for you too.
Awesome. Okay. Thanks, Catherine. So here we go. So I too want to add my acknowledgement of the lands that we live, work, and play on. We are incredibly fortunate to be here and have an important role in being in advancing equity and in learning about our colleagues and friends and people we work with on these lands and that we share these lands with. So I'm going to give a little bit of a background on myself and talk about ICES costing macros, particularly the get cost macro, and then I'll focus the talk on methods using 2 examples of projects that I've been involved with that could provide some meat to the bones and give us some specific ideas to hang our hats on. So if you haven't seen the advertisement for this talk, here it is. I can take no credit for this. Thank you to the organizers. I don't know if economics could ever be this exciting, but I am going to try my best. So here we go. As you heard, I'm a radiation oncologist, a health services researcher here at Queen's. I have been generously supported with research chair funding through the Ontario Institute for Cancer Research. And I am transitioning to a Clinical Teachers Association of Queens CTAC chair in applied health economics and policy through CTAC and generosity of CMO. I'm incredibly grateful for this honor and opportunity. So to do these projects requires a large team because it takes knowledge of health administrative data, economics, the clinical side, which is very multidisciplinary, transdisciplinary. I want to especially acknowledge and honor Paul Nguyen, who's been involved as the senior ICS analyst and biostatistician on these projects. He could tell you much better than I could about these algorithms and all of their nuances and complexities. So I see Paul's online, which is great, and I really want to thank him for leading the analytic work on these projects. There's a diverse members of QHS and HSPRI that are involved in many of the projects that I've been involved with at CCE, oncology, nursing, and so many other areas where it's quite the team. One of the projects is connected to CLIO, the Canadian Network for Learning Healthcare Systems and Cost-Effective Omics Innovation, but that shortens to CLIO somehow. So I'll tell you more about CLIO as we go on. As well, partners have involved from Sunnybrook, Princess Margaret, and the Canadian Cancer Trials Group. I don't think that my survey is going to work. I think my Wi-Fi needs to be set up there. You can try going to slido.com and literally it's just that short address and put in 315-6583. I'm going to go there too on my phone just to see if I can get something to work. But I think I may have had to have my Wi-Fi set up on my other computer and it's not cooperating. So we'll give it a quick try. Nothing lost. It says there's no such event right now. I'll try one more time.
I seem to get something, Tim.
Okay. All right. Let's see. It's not showing anything yet. We'll go to this next one. No. Oh, someone sent me greetings, which is cool. But yeah, it's not going to cooperate. We'll do a word collage another time, but this is the question you can think about as we proceed. When you think of health economics, what word comes to mind? And it might be cost, it might be outcomes, it might be headache. I don't know, but hopefully there'll be more positive words after we're done chatting today.
Tim, we're in actually. I've seen people like putting things in actually. You might not be able to see it, but I do, and I can actually read out what people are saying. So
that's yeah, okay. Yeah, I see demand and supply and cost. Yep. That's great. if this worked properly, we would see an animation in front of us with words spinning around and getting larger and smaller depending on how many people type them in. But you know, we're learning methods today, so come to my next talk. Maybe we'll get it working. But there's a lot of ways to define health economics, and just one of them is this. Health economics is concerned with the problem of allocating healthcare resources under conditions of scarcity and uncertainty. Scarcity, you have to make a decision because you only have so much resource. And uncertainty, we don't always have all of the information we need to make the perfect decision. And so health economics addresses that. So many different questions we can ask within health economics. Some of them are here. What is the cost of healthcare? What is the outcome? What influences cost and outcome? And what is the relationship? What is the relationship of these things? Some of the traditional tools that can be used in health economics are economic models. There's a picture of a Markov type model there. These require assumptions and often stitching together data from many different sources in order to create a model that reflects your situation as closely as possible. And so that has pros and cons. The pro might be that you can get a model out faster than you can collect fulsome information out of a trial or wait for the data to be available in health administrative data sources. The second way, as I was alluding to, is collecting the data by hand within the trial or within whatever situation you're in order to undertake an economic analysis. So this is example number one. This is an economic analysis of a randomized clinical trial using clinical trial data linked to ICS data. So this involved Dr. Annette Hay and many others through the Canadian Cancer Trials Group. And we took a historic trial that is almost 20 years old now called the CO17 trial. It was a landmark trial that showed that there were some benefits for specific patients with advanced incurable colorectal cancer who really had no other options. And so in Dr. Hay's work leading up to the project that we collaborated in, they looked at taking that that cancer center data and linking it into ICS. And there were no health card numbers, so they had to do what's called probabilistic linkage to link the trial data to the administrative data with the highest level of certainty possible. And when they did that, initially there were 572 patients in this trial that was published in the New England Journal of Medicine, but only a subset of those patients were treated within Ontario. And amongst those 162 patients, 148 or 91% were successfully probabilistically linked. And this is the subgroup that we did this pilot work on at ICES Queens. So one of the reasons we chose this particular setting to do pilot work is that there was a really nice economic analysis published in one of the major cancer journals on this CO17 trial. So we had something that we could compare to. And in this economic analysis, a lot of trial staff for the cancer centers that were involved in this trial across Canada hand collected information that was used to measure how many times a person got a blood test, went to the emergency department, got admitted to hospital, and for how long, and so on. So it was very detailed information to collect and took a lot of time and effort to collect that information. So this is the study where we looked at data linkage, health administrative data linkage, to see how it performed against this very well conducted trial economic analysis. So not only did we want to just redo the cost effectiveness analysis, but we also wanted to compare specific utilization. So for example, how often do we see the same number of hospital admissions for someone in the trial data as we do as in the ICS data? So we undertook a few different analyses, one up to the trial data last contact, so that we were comparing apples to apples in terms of the follow-up time, and a second economic analysis where we used the follow-up data as far as ICS would allow, just to see how that might affect the survival and also the utilizations and costing. And we used an ICS algorithm that some of you may know called the get cost algorithm. It's used a lot and has some really good documentation. And so I'll chat a little bit about that as we go along. The last thing I'll say is that for this particular example, because this trial happened almost 20 years ago, ICS didn't have Cancer Care Ontario data on drug use. So that part we had to patch with information from the Canadian Cancer Trials Group. If you want to learn a little bit more about the different aspects that you might put into an economic analysis with ICS data or with other methods, I would suggest you have a look. Well, there's lots of good sources out there. The Cheers checklist is one good place just to get a sense of some of the key things to include. The Consolidated Health Economic Evaluation Reporting Standards last put out, in 2022. And I'm just highlighting the perspective of the economic analysis, because that's really important when using the get cost macro, because what the macro and the ICS data most readily allows you to do is understand what the costs are from the public healthcare system payers perspective. So it in general does not include broader societal costs, or particularly patient and family out-of-pocket costs, for example, cost of travel, lost income due to missed work or caregiver duties. So that just needs to be taken into account when you're deciding when and how to use the ICS data. So if you would like all kinds of details about the get cost macro, this particular document is a really nice source from 2013, and it's got piles and piles of details. The beauty of the ICES health administrative data is that there are very broad linkages that bring together a broad range of data sources that you can use for determining when and how often utilizations happen from a very broad range of sources. And these are a list of the sources that we used in this particular CCTG project. And most of these are from the get cost macro, except down there where it says the cetuximab and some of the drug and delivery costs. Up at the top under the row that says short episodes, I've put in a red box the costing method for the acute care episodes. And I'll go through that in a little bit more detail, just because it's a common driver of costs, so it's a good one to think about a little bit more. There'll be a touch of math, but I promise not too much. So RIW times CPWC, that's resource intensity weighting times cost per weighted case. And so this relates to, as you can see in the last column, inpatient hospitalization, same-day surgery in CAI SDS, and ED visits. So this is what the math looks like, and the case cost is what you would get for a particular person that goes through a number of different episodes of care that would be over a set period of time that you could specify. So, like, for example, within 6 months of their date of diagnosis, or within a certain time of a certain treatment, that can be specified. So that resource intensity weight is a combination of a whole bunch of factors. The CMG, case mix group, which relates to what kind of condition a person has, the person's age category, and those go into the base resource intensity weight. And then there are a number of other factors that are used to nuance this at the person level, such as comorbidities. And important thing about the resource intensity weight is that it's linear. So if you have a resource intensity weight of 1, that is half as much resource or cost as someone with a resource intensity of 2, and the person of 2 is twice as much as the person with RIW 1. And as best as I can tell, RIW can just continue onwards. I don't believe there's a cap, though maybe later we can go back to that, Paul, if you have some thoughts or others. So that's the resource intensity weight. The cost per weighted case looks at basically all the costs at a specific geographic unit. Usually it could be the whole province, could be the hospital, and that's divided by the total weighted cases. So every person gets a resource intensity weight, and then you add together all of the individuals at that hospital's resource intensity weight to get the total weighted cases. The total acute care costs includes a lot, but some things it doesn't. For example, a major capital building project wouldn't have the costs in there. Some of the IV cancer drugs aren't in there, I don't believe. Some of the imaging costs, but anyway, it is fairly complete, and so that's the cost per weighted case. So you take the resource intensity weight that we saw in that previous figure, the cost per weighted case, and we multiply them to get the individual case cost. So going back to our CCTG study, I'm just putting up a very brief table 1, just simply to say that the characteristics of the Ontario subcohort that we looked at was fairly similar between the cetuximab and supportive care group. So cetuximab was compared to no specific drug. Those patients, because they had no other options, they just got supportive care. So the first thing we did was to look up to the trial date of last contact and limit the ICS data to that, and to compare how many times each patient was hospitalized or visit the emergency department. And the number of times ranges from 0 to 2+. So the patients that had encounters were more within the blue bars, the administrative data. So less of the ICES-based analysis patients had 0 hospital visits or ED visits. And you might ask, well, why might that be? We can only guess. It might be that sometimes people were very sick and they simply failed to mention a visit. They were only asked at certain time points during the trial, and maybe they thought that they had mentioned it the last time and it got missed. It's a little hard to say. But for those people that had data in both sources, so the visit was captured in both sources, we did find that there were cases, even in those patients, that weren't always captured in the clinical trial data. When you look at survival as measured by the ICES administrative data compared to the trial data, you can see that the survival curves look almost identical, and the hazard ratio also is almost identical. Probably most of the tiny difference that we're seeing is due to longer follow-up within the ICS data, because a clinical trial is set up and funded to only follow up people so long, and then a decision is made at a very specific point to stop collecting information. So this is a table of disaggregated costs for the cetuximab group. That's in the first set of columns, and then in group 2, the supportive care group. And I'll direct you towards the mean cost, which is the second of the 2 columns for each group. And the mean cost for hospitalization was higher in the cetuximab group. That could relate to visits because of toxicity, and management of toxicity, or it might mean to a small degree that people were living longer, so they just had more time to visit the emergency, the hospital. Emergency departments, actually, the costs were pretty similar. The costs for specialist visits, if you go down further to the next red box, this was also a higher cost in the cetuximab group. And that might relate to just more treatment visits to receive the investigational drug. And then down where the row says cetuximab at the bottom, the last red box, there are very big differences in cost there because only the investigational group got a drug. So mean cost of over 20,000 for the cetuximab drug versus 0 for the supportive care group. And that really drove a lot of the differences when we did the cost effectiveness analysis. So if you look at this table, it's showing you what the mean costs and mean life years were for the cetuximab and best supportive care group, both for the original trial economic analysis and then the ICES analysis. And you can see that the mean costs for the cetuximab group are higher in the ICES data, even when we limit to the same length of follow-up. So this isn't a follow-up issue. It's just that the costs are found to be higher. And also the same for the best supportive care group. And that could relate to differences in how individual utilizations were costed. But interestingly, when you look at the cost difference, the mean cost difference, that was almost identical. Perhaps that was driven by the very high drug costs in the cetuximab group. The mean life years was also very similar between the two analyses. And now this is the same table with another analysis put in the bottom. This is an ICES economic analysis data set that goes to the maximum follow-up for these patients that was present within ICS. And when you do that, the costs are higher and the mean life years difference between the groups is also higher. So you could expect some difference in the incremental cost effectiveness ratio. And this table just shows differences in the ICER, ICER incremental cost effectiveness ratio, similar values between the original economic analysis and the ICS one up to the trial date of last contact. But then if you use all of the follow-up data and utilization data that you have for these patients within ICS, the ICER is actually lower, so closer to what might be cost effective, though this is pilot data on a small group, and if you look at the confidence intervals, they're incredibly wide. So definitely this is taken with a very large grain of salt. So just to touch on strengths and limitations, the ICS data for a comparable period was found more complete than the trial collected data in this case. We found that key cost drivers could be measured with the ICS data, and the ICS data does contain information on subsequent lines of treatment, though we have to consider more recent time periods. So newer trials, if we did this again, we would have better drug data. And importantly, in a survey that Dr. Hay and others did, asking patients if they were okay with their trial information being linked into sources like ICS, there was a very high receptivity and I think in some cases a question of why aren't you already doing this? I thought that you were already using my data as best as you could. In terms of limitations, if you were to do this for a national clinical trial, then you need to go through this whole process with each province and set up maybe some kind of central repository, maybe through federal source. And that could take a lot of time and effort. And so that logistics side needs to be considered very seriously. And Dr. Hay is going through that experience with a lymphoma trial right now. And it is not a simple thing. and there could be differences in even the administrative data sources between provinces. I think definitely you can think of this sort of analysis as complementary rather than always replacing something that would be done within a given trial. So there's a QR code for you if you'd like to read a little bit more about the benefits, opportunities, and limitations of this sort of linked economic analysis with trials. This was an article that we wrote together in BMJ Open, and Dr. Brooke Wilson led the charge on this one, and it's a nice summary. Maybe I'll pause there before I jump into the second of the two examples.
And say if anyone wants to put any questions in the chat, I can help you see those, Tim.
Okay. I don't see anything now, but I mean, if you're typing, keep typing, and we can loop back. Oh, sorry, I see a hand.
Yeah, this is probably an ignorant question, but just how much, like, to do that probabilistic sampling, I think you call it, but just so you don't have the actual people, but you're based on the information you have, you're predicting people who would look like them. Is that what you're doing? And how much data did you have to have about the original sample to be able to do that?
Yeah, so I'm not sure of the variables that were used in that probabilistic linkage, but I believe they were ones that they had initials on the patients, date of birth, sex assigned at birth, the type of cancer that they had, the year of the cancer diagnosis, all of those, they all help, and I believe what they do is assign a level of certainty, and then if there are too many people that look the same, then no assumption is made. But I can say, looking at what we got out of that probabilistic linkage, that that the quality of the linkage for those people that were linked was very high, and we didn't get any kind of unusual cases that just didn't make any sense, like treatment 10 years after the trial, or weird combinations with the hospital data. But really, I think if this were to be done again, it prospectively, we would consent people for their health card number and do it deterministically. And actually, the second example, that was done.
Tim, there's just one other question in the
Sure.
Jean, would you like to?
Yes, thank you. Can you hear me?
Yes, thanks, Jean.
Hi, Tim. Thanks for this. So I'm not too familiar with this type of analysis. So my question was, like, what is the end goal of this type of analysis? Is it to kind of show, like, this particular drug has lesser value than this particular intervention, so we should, if you have a limited amount of money, it should go here and not here? And what's the evidence that doing this kind of analysis ends up in that kind of goal? I don't know if you're following that.
Yeah. So, like, why do this, and does it work? So this sort of incremental cost. So first, to say, there are many different forms of analysis within health economics. Some look at the cost of the treatment and the economic benefit, a cost benefit. Some just separately look at the cost you have to spend and the outcomes like survival or quality of life, and just take that to the decision maker so they can think about it. Others are more formalized in, like what I just showed you, where you determine the incremental cost effectiveness ratio, and you get this ratio of cost to outcome, which is either survival or quality adjusted life years. And that kind of analysis is often used in health technology assessment. And for example, in Canada, it's a formalized part of drug decision making. So that kind of that ICER is used in making recommendations to provinces on funding and whether the drug represents good value for the payers or not. And that does relate to the fact that some drugs are way too expensive and others offer very little benefit. And so there is a typical threshold that's used. It varies between countries and maybe even decision makers, but often there's a $50,000 threshold that's set. So like for what I was showing you, which was in the $100,000 to $200,000 range, that would, decision makers would look at that and say, yeah, that's not looking so exciting. And in fact, what I didn't get into, but an important part of the cetuximab story was that they found that when they looked at patients who had a specific genetic marker, though that particular group benefited, and those are the ones that typically go on and get the drug, and not the other ones, because of differences in the benefit and the cost effectiveness.
Great, thank you.
All right. Well, that's actually a perfect segue into the precision medicine part. So precision medicine is a model for healthcare delivery that relies on data analytics and information with the ability to guide healthcare decisions tailored to specific patients. And these pictures are just little graphics to do with the kinds of trials that are done in the precision medicine and precision oncology space. We have umbrella trials, basket trials, platform trials. Some of the general idea is that, say you had a bunch of different kinds of cancer patients, lung, breast, prostate. If they had a specific genetic alteration, some of these trials would just say, I don't care that you have prostate or lung, you've got the marker, so let's treat you all the same way and see what happens. So that's one aspect of precision medicine, but it goes much broader than that. The thing about precision medicine is that it involves many small subgroups because only so many people have these genetic markers. Sometimes you almost have a magic bullet if you have the marker, but it might be only 1% or 1 to 5% that have these markers. And as it happens, many of the precision oncology studies don't have a comparison group as a traditional randomized trial does, which you might have a major issue with, and I think you should have a major issue with that, but that's the situation that exists within this space. And this is, technology and technology changes rapidly, and so do the drugs that are available. So this is an additional challenge. So this, ideal future state, we'd have this wonderful learning healthcare system where you'd have a drug pipeline leading to amazing clinical trials, the regulatory process where they might look at the ICER, and then eventually you get real-world data as we get in ICES, and then that real-world data could provide information that informs the regulatory process, trial design, and a selection of groups of people that have unmet needs where we could go on and do trials that are relevant to them. So this is back to that mouthful, CLIO. This is the group. It's a pan-Canadian group involving many different stakeholders. The leading group, I would say, are from British Columbia. And I was one of the co-PIs on this multi-year project. And the goals of this project were a few, but the one I'll focus on is activity 1, where we undertook pilot projects to think about methods and help develop better methods to deal with the economics of precision oncology. So I got involved in an Ontario pilot project that was led by the Princess Margaret Cancer Centre and UHN and Ontario Institute for Cancer Research, who also funded my research chair. And what they did was provide funding to centers across Ontario to capacity build and help these centers set up the equipment and the human capacity to be able to do sequencing on numerous genes of people who have advanced cancer, advanced solid malignancies. And typically this would represent sequencing of over 500 alterations per patient. And so it's a lot of genetic information. And they did consent people to provide their health card number so that they could use the administrative data. There was some thought to collect clinical data directly through this project, but interestingly, not much was moved forward on that. So essentially, without ICS data, there was no option to do any kind of outcomes analysis or economic analysis. So ICS was and is a very important source for this precision oncology project. And the idea behind having this information was that it could be used to pick new cancer treatments for people with cancer, though notably these would be often on clinical trials and possibly even out of pocket because they're not even approved by Health Canada for that specific indication. So in our initial work, we just looked at how many people had genetic alterations in our initial data set, what they were, and some of the common ones are listed here. And then importantly, we looked to see how often that information was actually used. And so we found that almost 28% had some kind of usable genetic alteration, genetic information, and about 17% of those 28% actually had that information used as best as we can tell. So what that works out to is that only about 5% of people after they enrolled in this Octane study appear to actually have had that information used to guide treatment decisions. Not that they didn't have treatment, but just that as best as we can tell with all available data, it seems only a small number actually had that information used. So you wouldn't expect large differences in survival. Even if you magically cured that 5%, you wouldn't see the survival curve budge very much. And so that influenced our thinking when we were setting out to do an economic analysis, because if you want to do that ICER like we did before and make a ratio of cost to outcome, if your outcome is it's the difference in cost on the top and the difference in outcome on the bottom. So if there's zero difference in the outcome, you can't really do that math. So we decided not to go down that ICER route and did something a little bit different called the cost consequence analysis, which I briefly mentioned before. And this is just an analysis where we lay out the costs in a disaggregated format. So like, for example, like what are the costs of drugs? What's the cost of hospital admission? What are the costs of physician visits, et cetera? And then we looked at a number of different outcomes, and just so that people can look through it, think about it, and get a sense for, you know, what the impacts are of this intervention. Even if it's not really changing survival, is it having any other effects? And you can see there's a very long list of authors, and that just relates to the fact that we need experts in genetics, in oncology, in ICS data, health economics, analytics, and on and on. So in palliative care, you see Danielle Kane is on there. So this is a very a large group to do this sort of project. And the other thing I'll emphasize is that we need large data sets. So on the left, the column of information relates to the actual Octane trial group, which starts with 1,217 patients. And on the right is the column of information related to all the people in the Ontario Cancer Registry. So we started with over 1 million people in the Ontario Cancer Registry that we could use for matches. When we limited that to those that had palliative treatments and thus incurable cancer that we could, at a very high level, compare to the Octane patients, we were down to about 200,000. And then when we limited even just a touch more and said, you know, we want to compare lung cancer to lung cancer. We're not just going to compare, you know, to any kind of cancer. So very simple limitation. Now we were down to about 33,000. And this is, you know, just to emphasize that, you know, I mean, when you're talking about precision medicine, you need humongous data sources. We didn't even get down to matching, you know, a specific mutation in a patient to another patient that had that mutation. This is we're fortunate to have the data we do in Ontario. So ultimately, we ended up with 782 patients, propensity matched in each group. This is a table from the proofs. So please keep this to yourself. It's still not out in the public yet, but we presented stuff like this at other presentations, so I'm okay to present more on it today. But in these red boxes, you can see for just a small selection of the characteristics we matched for 19 different patient and disease characteristics. You can see that there were important differences in these factors. For example, if you look 4 variables down at place of residence, there's a big difference in where people were coming from in the province, and there could be all kinds of factors related to determinants of health that might be different between regions. But the bottom line is that after we went through the process of propensity matching and Paul did this exercise, we ended up with good matching. We were looking for standardized differences. That's the STD DIFF of 0.1 or less. So we were able to achieve that. These are all the costs for the matched cohort. You call this a disaggregated cost because that get cost macro again is showing us what the costs are overall and for these specific groups, and you see total costs and mean costs. And looking at the octane group, that's the first set of columns compared to the no sequencing group, at least no multi-gene panel sequencing. A big difference in costs related to simply visiting clinics and seeing the oncologist. So the octane patients, I think, would be more likely coming in, talking to multiple doctors about clinical trials. And so maybe this might reflect some of the costs of simply seeing people for further lines of therapy. The octane patients went through more types of systemic therapy. And I think that reflects some of that cost difference. And then you look at the bottom big rectangle, and this shows differences in the total costs without any drug-related costs, and then the total with publicly reimbursed anti-cancer drugs. So in both cases, higher costs. If you were to look at specifically what the differences were in the publicly funded drugs between octane and non-octane and the drugs that presumably were paid for out of pocket, you would see that the big difference were actually in the non-public drugs. And in fact, the octane patients, I have to look back at this, but I think they actually had slightly lower publicly funded drug costs because like when you go enroll in these trials, it's often the trial, the industry that would pay for the drug. So some differences, but ultimately there were greater costs for the octane group. This was survival, and was as expected that the curves were very close. In fact, if the curves were widely separated by 10% or more, I think we would go back and say, what kind of confounding are we missing here? So in some ways, we had a bias towards expecting that this would be what we would see for this analysis. If you then take these same patients and then divide up into specific cancer types like breast cancer, ovarian cancer, et cetera, some of the differences in survival were slightly different. In a couple groups, even after adjusting for multiple comparison, there were significant differences in survival for some subgroups. So what about other outcomes? Because he said we were doing a cost-consequence analysis. So in this particular study, the other thing that we looked at was end-of-life quality of care. There are a number of metrics that are established and that you can use administrative data to measure the end-of-life quality against benchmarks. And so this was something we looked at, and it's acknowledged that these are, you know, they're imperfect, and they give us a window into what's happening to people dying of cancer. And there are other metrics, and we need better ones. So ongoing work. But just to point to the bolded death in acute inpatient care, what I hypothesized, and the reason that I thought this would be interesting to look at, is I figured that with all of this intensive, aggressive attention and care being given to the octane patients, that maybe there would be some forgetting about ensuring that end-of-life quality of care was as good as it should be. And maybe, you know, I thought maybe we would see a lot of fighting to the end and a lot of extra visits compared to the matched population. But actually, when it came to dying in an acute care hospital, the octane group had a lower proportion of people dying in hospital, not large. It was, but significant, 16% for no octane versus 10% with octane. So yeah, just something of interest and something a decision maker might want to know and maybe clinicians might be interested in, but definitely needs to be replicated in other studies. This would be the first time this sort of association has been shown, so it needs to be looked at more. And just thinking about cost-consequence analysis, ICIS is beautiful. I mean, it gives us a lot of opportunities to look at other outcomes that matter to patients and their families. And in this study, a different one, and I won't get into the details, we looked at something called time toxicity, which ICS data is beautiful for. This is a measure of the days that people spend in healthcare contact outside the home. So when people are dying of cancer and don't have a lot of time, you can imagine that, you know, if you have 2-3 months left of life left and you're spending your time on, you know, visits to hospital, that could be time maybe you would want to spend on something else. You know, it depends on your perspectives and what you want to do, but important information that could factor into clinician discussion with patients and also for clinical trials and thinking about the benefits and risks of treatment. So that's another one, time toxicity, or you could, it's now called contact days is the other one. So even we can look at if people leave home to go get blood tests, we can factor that in with the OLIS data at ICS. And that was something we did as one part of this. So real world data such as through ICS can be useful in situations like I showed you with the octane data. We get statistical efficiency. There's plenty we can use when it comes to doing causal inference type analyses and trying to compare groups. And in terms of the actual analysis, it's a lot cheaper than collecting all of the information in a trial in many cases. And there are some measured examples of that. But of course, bias and confounding are major issues. And I won't get into some of these other things, but as always, there's pros and cons. So in conclusion, health administrative data from a universal healthcare system can be a powerful resource for health economics, and that might be in trials, and it could also be in economic analysis involving real-world data where we need to develop a comparison group. And some of these benefits are the reflection of real-world practice and outcome that we see in the ICS data. Costs of analysis, at least to the investigator, are probably less. The assumptions are fewer and different than if you use an economic model, and the data may be more complete than hand-collected data and very often with longer follow-up. So I'm going to stop there, and if there are more questions, I'd be happy to take them.
Thank you, Tim. That was fabulous. You have set the bar very, very high. Yeah, I've learned so much. I particularly really like the examples of like going through the 2 different trials and different ways of approaching it. I have a few questions, but I will hold them for everyone else. Rebecca has her hand up. Maybe Tim, if you want to stop sharing the slides and then. Perfect.
Hi there.
Awesome.
Really interesting presentation. I was wondering what you think about for the potential for like equity research fitting it within health econ. Like I'm thinking here about comparing between like general pop versus a marginalized group and seeing differences in healthcare expenditures.
Yeah, thanks, Rebecca, for bringing that up. It's a really good question. In fact, that was almost the same question I got asked in my interview for this chair. That the ICS data is beautiful because it has information on so many people. And it provides an opportunity to start to think about that. Usually when we see economic analysis for decision making, anything I've seen has not been able to delve into assessing cost effectiveness for equity deserving groups or almost any group apart from their genetics. So I think it's a really important point, and it's an area that is ripe for work and development. I mean, it does go back to ongoing discussions about the need to measure when people are part of equity deserving groups, and to do so in an appropriate and privacy respecting and respectful way. We need that in order to compare what's happening between groups. But yes, it needs to be done. It should be done, and that's something that that Queens could lead. The one thing I'll say is you need information on a lot of people. So I don't know if you saw those super wide confidence intervals on my first example, when I had, I think it was around 150 people, 70 or 80 in each group. So if you're talking about groups of people where you don't have a lot of individual level information, you're not going to be able to do meaningful analysis. So it really does have to be on a pretty large sample if you want to have statistical power. I think you can still get good information on the small groups, but you have to kind of respect the limits of what the data is able to tell you.
Thank you.
Thanks very much, Tim. Now, I know a few people sort of had their hands up tenderly up and down. There's a question in the chat, but I know there are a few people have put themselves on video. Do you have any questions that anyone here wants to ask?
Maybe I'll pipe in. Great presentation, Tim. Really sophisticated analyses. I know the oncology clinical trials group is well ahead of that. I think it's mandated by a lot of your trials now to have an economic analysis important. I come from the area of primary care, and we don't really get into it as in as much detail, but the ministry is starting to mandate that they want some economic analyses as part of our studies. Do you regularly have a health economist? I didn't see you mention that as a part of your team, or you just rely on Paul's expertise as a biostatistician? Can you comment on that?
Yeah, it's a great question. So on all of the projects that I've done up to this point, I've been sure to have a health economist on them. But I have to say that a lot is learning as I go, and definitely rely on great help by Paul and people like Paul to help with the hands on the keyboard and some of the detailed aspects of it. But health, like finding a health economist who has some time to get involved in a project can be hard. And I mean, thankfully, some of the get cost macro is it's overall very well maintained. It's got a lot of documentation. So doing things like describing costs of things is very well suited to what the macro can do. So it makes economics more accessible, I would say.
Thanks, Tim. That's great.
Great, thanks. We've one last question, Vic, and then we'll wrap up. And I've put a lot of the papers, Tim, that you've talked about in the chat for people.
Sorry, did you say Vic?
Yes, Vic, sorry.
Oh, excellent. Congratulations, Tim, on absolutely brilliant talk. And congratulations to ISIS for supporting this. One of the questions I have is, have you ever thought of linking survey data? So for example, the community healthcare data to ISIS data, and there you might get more information about equity and other factors.
Yes. So, that data can be linked in. And I mean, the things to think about are sample size and getting consent to link in the information. So, some of the work I've done has used Ontario-wide survey data which provides area level responses. So like, for example, smoking, there's no smoking variable for an individual, but you can get area level smoking information from surveys. So yeah, it's just a question of how you use the data, but ICS has a nice streamlined process for data linkage and bringing in that information. And so that's a really important way to really optimize analyses and to give them a distinctive flavor within ICS.
I'm just looking at the time here. It's exactly 1 o'clock, and I just want to say, echo everyone's gratitude and really what a great kickoff to Methods Monday. Just so excellent to be able to dig into the details behind papers. I feel like it's what I'm always wanting to talk about in presentations. Just a heads up that next month we are going to have a wonderful presentation on natural language processing. And in March, Tim, you talked about propensity matching. We're going to whole talk on propensity matching. So a really opportunity to sort of like dig under the hood of methods and just highlight people who know all of this information. So now everyone knows that Tim's your person, as is Paul McEwen, who's hopefully is on the call, and lots of shout outs. So we will be posting the YouTube of this recording once that paper is out, Tim, just because we know that's sensitive information. So we'll have a YouTube channel just to the methods, and we'll also create all the links to all the papers that you referenced to, Tim. Just wanted to say how wonderful it was and what a great kickoff.
Wonderful.
Thanks, everybody.
Thank you.